Good morning. I'd like to call the October 27th, 2025 Board of Health to order. And I would now ask the clerk of the board to take the roll call, please.
Supervisor Juan Gold.
Here.
Adams. Board Member Coyle.
I'm here. This is Coyle, but I can barely hear you.
Yes, same.
Same here.
Board Member Stewart.
Here.
Board Member Litz.
Here.
Board Member Stricker.
Present.
Board Member Sheehy.
Here.
Board Member Thomas.
Here.
Dr. Nguyen.
I'm here.
Director Palmer.
Present.
Okay, we have a quorum.
Okay, would everybody please stand and join me in the Pledge of Allegiance? I pledge
allegiance to the
flag
flag
of the
United States of
United
America
States.
and to the republic for which it stands, one nation under God, indivisible, with liberty and justice for all. Thank you. At this time, I'd like to make the call to the public. Do we have anyone that wishes to speak at this time? Well, I don't see anybody rising, so we're going to close that portion of the public hearing and move on to our business. First up, we have the presentation portion of our thing today here. And the first presentation regarding Senate Bill 1247 is going to be by Kelsey King, the Community Health Education Specialist Senior. And Kelsey, I'd like to turn the floor over to you.
Hi. Sorry, excuse me. Okay, so my name's Kelsey. I work with the Mojave County Tobacco Use Prevention Program here in Arizona, or Mojave County. To go ahead and start, Arizona has passed State Bill 1247, which is considered the Tobacco 21 law. It raises the age of purchase to all tobacco and nicotine products to 21 years of age to match the federal law that was passed in December of 2019. In the Arizona state law specifically, there are two exemptions that aren't recognized in the federal part of the law. Those two exemptions are for active service members in the National Guard or the United States Armed Forces, active or reserved, and they have to have a military identification card when they are buying the tobacco in order to be a part of this exemption. They can't provide like a normal driver's license. And then the use of tobacco in connection with a bona fide practice of religious belief. We do see that in Mojave County when it comes to the Native American populations. It is considered a sacred plant. However, ceremonial tobacco is not a traditional commercial tobacco, so they cultivate their own tobacco. It's not the traditional sense of cigarettes or chew or anything like that that's currently on the market that they use in their practices. So the reason why Arizona did this to match the federal law is, and really it comes down to protecting youth and helping them not form addiction problems. So nicotine can affect a young person's impulse control, memory, and moods, and their brains continue to develop until about they're 25 years old. It has been proven that those who can avoid a nicotine dependence until 21 years or older, they have a lower odd of having a nicotine dependence, but also a higher chance of actually quitting if they do end up smoking and having a nicotine dependence versus someone who, say, starts at like the age of 15. They have lower odds of ever quitting tobacco. This law also closes the gap that was seen in Arizona, where local police department and the Attorney General's office could only cite tobacco retailers if they were selling to kids under the age of 18, even though the federal law was at 21, the local police department and Arizona Attorney General have to abide and cite under Arizona law. So for the past 6 years, there's been kind of this gap where tobacco retailers could sell to those who were 19 and 20 years old because the local police department couldn't, or the Attorney General's department couldn't cite them under federal laws. So this increases the compliance to be on par more with the federal law. To give you an overall description of compliance in Mojave County, the FDA previously had only been able to come to the Mojave County about twice a year. They have since been able to kind of increase that and ramp it up. Right now, we have seen them out here already twice this year, but they are coming out for a third time in December to do some more repeat compliance checks on those who failed, and then to close the gap on the other ones that they haven't been able to reach out to yet. Right now, there's approximately 420 tobacco retailers in Mojave County. In 2024, from January to December, we had a fail rate of 21%. So 21% of retailers that were inspected did sell to underage minors, and that would have been at 18 years old and under. And then from this year, from January to present, we're sitting at about a 7% fail rate. And again, this law took place at the end of September, so that fail rate was mostly sold to, again, minors under the age of 18. And then how we support the Arizona Attorney General's office and the FDA with their compliance check program is we recruit youth to go through the program. In return, the youth get a letter of recommendation for college or any sort of program or volunteer hours that they might need from the Arizona Attorney General's office and the Food and Drug Administration. We work with various courts throughout Mojave County to provide education. So when they do fail a compliance check, we have them come in, the court orders them to come in with us, and we can provide education to better help them not sell to underage users. And then also we offer that program for free for any business that might want to train new staff, or if they're opening a new business or anything like that, free of charge through us. And it's all developed by the Arizona Attorney General's office, and it's called the Counter-Strike program. So that is a brief overview, and that's all I have for you today. If you have any questions, I am open for them right now.
Questions from the board? Comments?
I have a question, not so much question, but comment for discussion. The last time I'm actually practicing as a pulmonologist here in Kingman, a lot of outpatient, they actually come to Laughlin to purchase the tobacco. Number one, they said it's cheaper. I'm not sure if that's still the case. Number two, we have this new rule or policy here in Arizona. Is there any difference between Arizona and Nevada, or is the same? Do you know?
I am not sure about Nevada's state laws. I know that the federal law is 21, but I don't know if Nevada has, since 2019 when that federal law came into place, I don't know if Nevada has matched the federal law, or if their law remains at 18. I would have to go back and look that up.
So it's for us, just a kind of discussion to be aware of the geographical where we're at the county. So we know, and like you said, the key thing is education and, encourage our team to continue. So at the level of the board, we would like to kind of be aware of that situation, geographic location. That's all I have.
Absolutely, yes.
Commissioner Gould?
Thank you, Mr. Chairman. Kelsey, AGO's Attorney General's office?
Yes, AGO's Attorney General's, FDA's Food and Drug Administration.
I did not know that the Food and Drug Administration had enforcement capabilities.
They do have enforcement capabilities. They work in conjunction with the AGO's office. So generally, when they come out for compliance checks, there's one Attorney General officer and then one FDA officer that goes with the team that helps to perform the compliance checks.
Interesting. I don't think that the FDA has constitutional authority to operate inside the states, except they use their fallacious interstate commerce clause to get into the states, but that's kind of a sidebar. And just another comment, I wish we would figure out whether 18-year-olds are adults or not. So they have the right to choose our leaders, but they don't have the right to determine whether they can smoke cigarettes or not, unless, of course, they're a tribal member or a member of the military. And basically all males that age have to register for selective service anyway and are subject to the draft and go to war. So I just kind of wish we would determine, are they really adults or are they not really adults? Because it seems like they're not full adults. And a lot of this came out of the Vietnam War and the fact they were getting drafted and going to Vietnam and didn't have the ability to vote. But it's a sidebar comment, it's just rhetoric.
Yeah, no, and I can appreciate and understand where you're coming from. There's been a lot of talks about are they, at 18 are they adults, or at 21 are they adults? So I can't really say neither here nor there. I just know what the law has been passed and presented in front of us.
Right, and I agree cigarette smoking is bad.
Yes.
It killed all my grandparents, it killed my parents.
Yes.
So I agree that it's bad and that people are unwise to do it, but it's just that I get hung up on, are they adults or are they not adults?
Yes.
Thank you, ma'am. Thank you, Chairman.
Thank you.
Mr. Chair? You have somebody else?
Please, Byron?
According to AI, if you can believe it, the legal age in Nevada is 21. They passed a law in 2021 to align with the federal standard. So that question.
Thank you, sir.
Thank you for clarifying.
Thank you.
Curious turn of events. I thought if you're 5 years older, you could probably smoke up in Vegas, but I didn't know. So. Anybody else? I just found it a curious turn of events that the feds are trying to impose their will on the states here, but they will allow you, if you're in the military, technically you are a federal employee, they let you smoke, where it's a situation that they may wind up very well paying for it in the end.
Yeah, I would say the federal law doesn't have that exclusion. It's just the Arizona law. So say there's an active duty military person in Arizona, they can use their military ID to buy tobacco products, but I don't know how that goes state to state to state to state, because the federal law says no one under 21, and it's just the Arizona law that allows that leeway.
Anybody else have any comments? Okay, thank you for that presentation, Kelsey.
Thank you very much.
The next presentation that we have up is by Mr. Clint Welty, MPH, Dr. PH, Assistant Health Director. I'd like to turn the floor over to you, Clint.
Good morning, Board. So in years past, we have presented the results of the budget process, but this year we wanted to present to the board a few key items that we are going to be asking for in the budget period outside of normal budget expenses. And so to that end, we will be requesting an additional person for vital records. Currently, we have, for FY25, we had a total of 20,500 death certificates, and that's around 1,700 per month. 2,900 birth certificates, about 250 per month, and currently we are staffed with 1 full-time employee. As a comparison, Coconino County has 2 full-time employees and Yavapai has 2.5. So for FY27, we're going to request an additional person at a cost of approximately $68,000. So where the problem comes is with just 1 person, we're always way behind we estimate 3 to 4 weeks to get birth and death certificate orders completed just because they're so busy. It leads to staff burnout and turnover. It relies heavily on other staff to cover vital record services when they have their own jobs that they're responsible for. So that is one request. Another issue that has come up for the upcoming fiscal year, according to HR policy, county policy, et cetera, we need to transition temporary employees to permanent status. In the past, they've been considered temporary employees, and that has just continued for multiple years, and HR has let us know that that is not in line with policy. The main cost associated with that is health insurance. As temporary employees, they are not entitled to health insurance. So that's going to be the main cost associated with that. They will also start to accrue paid time off. We're estimating that to be around $70,000. Of the 7 employees, 2 are fully funded through grants. 1 is 80% funded through grants and 20% through general funds. And then for our senior programs, it's a little trickier. We do have grants and we expend all the grants. We use grant funds to fund everything until they run out, and then we do have to get some funds from general funds, but it's a little tricky to figure out exactly what the impact would be on the general fund. The third, and this won't have an impact on general funds, but we will be requesting 2 replacement vehicles for senior programs. Per county policy, they have to be replaced. I think it's based on mileage and years. But there is a fund that's set aside for that. The estimated cost is $56,000 per vehicle, so a total of $112,000. But as I say, there's funds set aside for that, so it will have no impact. One other thing, and I don't have a slide for this, but Director Palmer and I were talking this morning, and we did want to point out that we have had recently 2 grants that have ended. Health Start, and that served pregnant women and families and children under 2 with home visits, provide guidance, education, and support. The other is Arizona Health Zone. It was designed to promote healthy diet and physical activities in homes, schools, and communities. For both of these programs, we're working with local partners to try and make sure that services are still being provided to the community. Internally, we've been able to shift staff around a little bit, and so as of right now, we haven't had to let anybody go. And that's really all my presentation. So I'm open to questions.
Thank you, Mr. Chairman. I think your $70,000 number for converting 7 employees from part-time to full-time is low. I think our benefit package is about $20,000 a person.
So I got the numbers from the FY25 numbers. So they're already getting other benefits. It's just health insurance. And so for the health insurance portion from what we used to budget for FY26, it was what they had was 9,000 and something, so I kind of put it as 10. And of course, it will vary depending upon the level of actual insurance coverage that the person opts for. So It could be higher, could be lower.
Okay. I didn't understand that they were getting medical benefits as part-time employees.
They get some of the others, but not the health insurance.
Okay. So they don't get health insurance now?
No.
But they're getting part of the other part of the benefit package?
President Litz, Supervisor Gould, The temp employees, if they're 20 hours or more over a period of, I forget how many weeks, I want to say it's 20 weeks, they are signed in or signed up for ASRS, so they're going to get the retirement benefits, they get the workman's comp, and the only item would be the medical and dental and vision insurance. And that's only if they opt into it. That's the other thing, is if their spouse has medical elsewhere. That number is a moving target. I know in the past, budgets has provided $8,400 a year to cover that expense. But if they have their entire family on there, it could be $20,000.
Yeah, it
if
is
they
kind of a
don't opt
dynamic
in.
number.
Yes.
Okay.
So they do have ASRS, Arizona Retirement. They do have workman's comp, but it's going to be the medical package, medical and dental and
Thank you.
vision.
Thank you, sir. Thank you, Chairman.
Anybody else have comments or questions? Say, I did have some comments. I'm looking at the numbers that are issued on our sheet here, and did you give death certificate numbers and birth certificate numbers, or was it something else? Like, I've got, it says death certificates, 20,504 annually, birth certificates, 2,910 annually. Is that vary from the numbers that I heard you quote?
The monthly amount in my original PowerPoint was wrong. So the annual amount, so for death certificates, 20,504. For monthly death certificates, it's 1,709. I said roughly 1,700.
Okay, well, it just differs a little bit from the numbers that are on here then, because I've got 4,750 monthly for.
Yeah, that's from the original PowerPoint that I sent.
Okay.
Yeah, I realized by mistake and corrected it, but I don't think it got to you guys in time, so I apologize for that.
Still, even under the old numbers, that means that 17,000 people or somewhere in that neighborhood would have to move into Mojave County to keep our population stable. And I know I've got it oversimplified, but still it's going to be a big number of people have to move here just to maintain a stable population base.
So it's 1,700 monthly. So that doesn't necessarily mean that 1,700 people died. That's how many orders we have to process.
Okay.
So it doesn't that's not like the monthly death rate. That's how many orders we process. And so orders can be at time of death. You could have some cases where they have multiple copies, or it's, the person may have passed 5 years ago and his family is requesting a death certificate. So that's not that doesn't mean that that's the death rate for the month.
Okay, interesting. Thank you for clarifying that. Anybody else have questions or comments about this report?
I can add on the birth certificate side of things. That doesn't mean that is that many children being born. It's going to be whatever the requests were. So we see bumps in requests for birth certificates around the time that school enrollment's going on, or sometimes with adults, they're looking for their birth certificate to get a passport. So those are also not necessarily tied to the birth rate for that month, but it's just based on requests.
Interesting way of accruing numbers, I guess. So, anybody else have any? Thank you for that, Melissa, by the way. It's interesting. Anybody else have any comments? Okay, well, Clint, looks like we appreciate your presentation, and we'll move on to presentation number 3. It's a presentation on the mobile health unit by Lynn Valentine, BSN, RN, CPM, Nurses Services Manager. Lynn, good morning.
Good morning. So this morning we'd like to provide a status update of the Mojave County Department of Public Health's mobile health unit. So I'd like to start with providing a little background on the development of the mobile health unit. The overall goal of the unit is to provide access to preventative health services to the underserved rural communities of Mojave County and to lower the impact of common health conditions. And of note, in Mojave County, the three most or highest morbidities that we have, according to surveys from 2024, are illnesses and diseases associated with cardiovascular disease, chronic respiratory disease, and cancers. How we do this, how we meet our goal, is by providing linkage to care, to health services and community resources, promote proactive care of one's health. One of our objectives is also to reduce the burden on local healthcare emergency and urgent care services. And the reason for that is because for our uninsured population, if they do not have a primary care provider, if they can't afford to go to one, then oftentimes they will seek care at the emergency room or urgent care. And then obviously another objective is to reduce the incidence of the highest morbidities, those that I just mentioned. One thing we are not is we are not a primary care service provider. We are not intended to replace anybody's primary care provider, such as a family physician, and we're not urgent care and we're not emergency care. We weren't designed to provide those type of services. So a little bit about the project timeline of the mobile health unit. In 2021, the American Rescue Plan Act, also known as ARPA funding, was approved and allocated for this project, which was under, at that time, Supervisor Gene Bishop for District 4. And so we started the process of trying to find a mobile unit company through the RFP process, building it out, what we wanted. This was all new to us, so we spoke to other agencies that had mobile units and talked to them to get their perspective and what worked and what didn't work. One thing to note is that this unfolded during and just right after the COVID pandemic. And it had a strong impact on the production and availability of materials and even in vehicles to build our vehicle. So the company we ended up awarding the contract to was based out of Virginia. They had challenges procuring a vehicle that could be outfitted with what we wanted, but eventually they did obtain a vehicle. We did know, of note, we did find out later that this was the first mobile health unit that this particular company had ever built. They had built other units, but not a mobile health unit. So the entire process was fraught with some trials and setbacks and that we in the company had to deal with. So there were many lessons learned about what we could do in the future if we were to build out another mobile unit or order a new one. But finally, by the end of 2022 in December, we got our unit. In 2023, it took some time, but we were able to recruit and hire a provider, and that was Miss Kathleen Walton, a nurse practitioner. She joined us in January, and then we were able to hire an assistant to go out on the unit in early to mid 2023. In March of 2023, we had a debut of the unit here at the county building for members of the public and local leadership to tour and check out. And then by July of 2023, the staff took it to a community event kind of for its inaugural visit. And by November, our staff had arranged a regular schedule of community visits and started their rotation of visits to several of Mojave County's most rural communities. Here you'll see a list of the communities served. These are the communities that our mobile unit visits right now. And although, as mentioned before, this was a District 4 ARPA project, the project originally was to focus primarily on District 4 communities, but soon after the unit started going out and making their visits, then Supervisor Bishop welcomed expanding the services to other communities outside of District 4. So that's why you'll see some of these communities are in some of the other districts. We started with 1 or 2 visits per month for each community, and then after about 6 months to a year, we reassess the demand in each area and then adjust the community's visits. For example, some that we didn't have a high turnout for visitors, we would start going out every 6 weeks instead of every 4 weeks, every month. And then if there were some places where we were getting a higher turnout, then we increased the visits to twice a month. Besides the regular community visits, the mobile unit will also participate in other community events such as the street team and various health and wellness fairs that are held throughout the year. I don't know how easy it is for you to see this, but this is the unit's promotional poster that is shared in the communities the unit serves, and then we also share it on social media. I have to take a moment to recognize our department's public information officer, Danny Lagana. She designed and created this, and she did a fantastic job with it. I do have larger copies printed out if you'd like to see those. So, and I do believe they were sent in some of the packet material that you all received. So on this slide are some of the numbers for a 13-month period from July 2024 to July 2025. As you can see at the bottom of the slide, we have listed the top 3 screenings that were provided during that time period, which were blood pressure monitoring, hemoglobin A1C, which is related to diabetes, and then cholesterol. Those were our top 3 most popular screenings during that time period. I do also have a graph where all of our screenings were broken down by month and by number, and I believe those were sent to you as part of the packet, but I do have them printed out if you'd be interested in seeing them. But on this slide, we have the services visually broken down in a bar graph, and you can see right there which were our most frequently requested and administered screenings versus those screenings that weren't quite as popular. On this slide, since this is a service for the communities, the feedback from the communities and the visitors to the unit, their feedback's extremely important because it drives our decisions that are made for the unit. So each person who visits our unit, whether they receive services or just are stopping in to say hi, which some people do, we do ask them to complete a brief customer service. This is just a screenshot of the survey. It's just brief, quick, to the point. It's not shown on this slide, but at the bottom they can also write in any additional comments or feedback that they may have that's not captured up above. The surveys are anonymous. We do collect them in a big manila envelope so that they're not handing it right back to one of our staff members, so that they can be as honest as possible, because we want that honest feedback. We track the responses and take note of what the feedback entails. And overall, the feedback has been very positive and complimentary. And just of note, for the first question, where it asks, if you haven't been here today, where would you have gone to seek service? And overwhelmingly, probably 75 to 80% of the respondents had stated nowhere, that they would have not gone anywhere for whatever issue they were seeking care or advice for. So they ended up coming to our health unit and talking to our staff and our nurse practitioner. Some of our successes with the mobile unit at this point include the increased engagement of community members from some of the communities we visit. It's taken a while to build up our client base. We continue to build it, but we take great pride in seeing those numbers increase with the visits and the screenings that we're performing in some of these communities. We also have and continue to establish community trust and dependability. Again, took time to build it. because there have been other mobile units that have gone out to these communities, and after a short period, they no longer are able to make their visits out into the communities for whatever reason. So some of the people in the communities were a little distrustful of us and weren't sure, if we were going to stick around. So we've really worked on that. Another success is, again, just like what our customer surveys reflected, that we were able to provide care or link people to care who may not have otherwise received it and not sought it out. So that's a big win. Some of our challenges, we've had some issues with our equipment, primarily some of the mechanical and structural issues that we've experienced with the unit itself. For example, the equipment falling off from inside the unit. We're going down bumpy dirt roads, things are getting jostled around. Figuring out creative ways to secure those items and prevent them from falling has been a challenge in some cases. We had a carbon monoxide detector that was continuously going off, which of course was alarming at first, no pun intended, but was alarming, but it turns out it had a short in it, or it needed to be replaced. So once we replaced it, we were good. I do have to give props to Mojave County Public Works Fleet Division because they've really helped us with that. And so I want to thank them for all of their help and continued support and for having patience with us mostly. Another challenge is, although we promote the unit as much as we can, we still know we have room to promote it more. Occasionally we still hear, I didn't even know you all had a mobile unit. And so we know that we could maybe do some additional outreach and promotion of the services. As with most small health units, we are limited on what preventative services we can provide due to what amenities our unit has available and what we're logistically able to accommodate. For example, limited storage space, appropriate refrigeration for vaccines, medications, things like that. And then finally, our last challenge is, and it's a big one, is future funding sources. ARPA funding is available only for a limited time. We know that. We do have the unit also split into one of our grants, but we will need to find additional grant support moving forward to help continue funding the program, especially once the ARPA funding is no longer available. And then finally, here is a screenshot of part of one of our monthly activity reports. We do report our activities for the mobile unit on a regular basis. On a monthly basis, the number of visitors to the unit and number of screenings provided is captured in the nursing division monthly activity report, which I mentioned is screenshot here, a snippet of that. And I believe each one of the board members here receive a copy on that monthly basis. On a quarterly basis, a brief overview of the mobile unit activities is provided to the county manager and other leadership. And then significant updates are also available in the ARPA dashboard under the District 4 projects on the Mojave County website homepage. And that concludes the update on our mobile health unit, and I'll be happy to answer any questions that any of you may have.
Questions from the board or comments from the board?
Lynn?
Yes.
This is Sandra Thomas from Fort Mojave Bullhead City. And I just have one question for you as far as the customer or client survey. I'm just wondering, it's a very short survey. I'm wondering why you're not obtaining a little demographic, psychographic information to help you with further decisions regarding the mobile unit. And I just wondered if that was something that might be valuable for you to include.
We definitely could. I do believe that could be valuable information. Our goal was try to make it short and sweet because we know more people are likely to complete it if it's short and sweet. And at that time when we created this survey, we really wanted to focus on what the community specifically were requesting and what the feedback was from the specific communities. So that's why we just have the communities listed on the survey. But we definitely could add demographic information on there to capture that data as well.
Yeah, knowing the number of men and women, their ages, I think could be incredible information, especially for grant capturing and other opportunities.
Agreed. Thank you for the feedback.
Commissioner Gould. Thank you, Mr. Chairman. Lynn, do we know what the mileage is of that unit?
I do not know off the top of my head.
Can you find out for me and let me know?
Yes.
Can we bill access for any of these services? I noticed some feedback. The last time I talked about the mobile health unit, I happened to look at the Teams chat where some people were saying that access does not transport. Well, I'm kind of curious how many of these people are covered by access, and can we bill access for covering them?
Right now, we don't have the capability. I mean, that's a whole, insurance billing is quite the process. We are working on that with our vaccine program. So right now, we don't have the capability because we don't have it in place. But perhaps in the future we can. That could be a possibility, especially when we're looking for other funding sources.
There's a methadone treatment van running around. Is that our van?
No.
Okay,
No,
so that's got nothing to do with us.
No, but we do, Fort Mojave, I believe it's in Fort Mojave, they set up, and sometimes we'll set up near them, but it's two separate entities. It's just, it helps with the
Both
flow of-
vans and...
Exactly.
Okay.
Yeah, one-stop shop.
Okay. Otherwise, if it was our program, we should probably run it out of the same van because we're already in the neighborhood.
Yeah.
Are a lot of the patients repeat patients month to month?
I don't know if a lot of them, but there certainly are. We have some people who will stop in, that's the thing that these surveys don't capture, is that we have some people, these are people who live out in these very rural areas, and sometimes they need some more human interaction or want to be with people. They'll stop by the van just to check on our staff or say, hey, can you check my blood pressure while I'm here?
So we're entertainment for...
No, I wouldn't say entertainment, but I'd say it definitely helps with the mental
As a rural
health.
citizen that lives in an extremely rural area,
Yeah, well,
it's odd most of the time if you live in a rural area, it's because you don't want human contact.
there's some cases where they kind of ended up there out
Sure.
in these rural areas under circumstances they didn't plan on.
So those are counted as patients?
As visitors, yeah.
So are they filling the form out?
Sometimes they do, yes.
Okay.
They do. They're offered. Everybody's offered one.
Okay. That is all. Thank you, ma'am. Thank you, Chairman.
Anybody else? Comments or questions? I have a few. So, you expressed some concerns about the funding, of course, and I see the original one started in 2021. Was that like a community development block grant that you divided up into timelines that just runs out, or was it for a specific period of time?
Are you referring to the ARPA funding or?
Yes.
So the ARPA funding is from the COVID pandemic, and that I'm not the expert on the ARPA funding, so Melissa.
I can explain it if you
Supervisor Gould, please jump in if you'd like to explain it.
Sure.
Go ahead.
The ARPA funding was American Recovery Act money from the Biden administration. The county received $42 million in ARPA funds. They had quite a few strings on them to begin with. As time went on, the strings were removed, so you could spend it on just about any project that you wanted to. The board decided to divvy that money up amongst the 5 board members so that we could make sure that it got spent equally in our districts. This was one of former Supervisor Bishop's projects but the board all voted on them. The entire board had to vote on them, but we basically let that supervisor do whatever they wanted with that money, and understanding that I would vote for Supervisor Bishop's things, and in turn she would vote for my things, because that was what I thought would be best to go into my district or into her district. That's one-time funding. That's probably never going to come back, which is why you don't want to spend it on reoccurring expenses. And that's somewhat of a problem with this, is we started this problem with one-time money, and now we have to keep it going. And will it become a burden on the taxpayer to continue to do this? Because the money, unless they pick up other funding, the ARPA money's done.
Thank you, Commissioner Gould. Anybody else have some thoughts? Well, you know, you caused a question for me. My question is does Mojave County pick up indigent and uninsured hospital bills, negotiating them down?
Not in public health.
Okay. Okay. Well, well, I guess I'm a little confused here, because if I'm indigent and I walk into the hospital and they've got to treat me and it costs $5,000, what happens to that bill?
If it's not paid, it ends up in collections.
I see.
Yeah, but they can't refuse somebody emergency care. So if they walk into an emergency room and say they're having an emergency and need medical care, then they can't refuse them care.
Very good.
To that point, that's for emergency care, not for ongoing treatment. So a lot of time, what happens is the hospitals go ahead and do the emergency care. They'll continue to treat that customer, and then they go back to the states and to the federal government and try to get paid for something that they're not required to do. So they act as if they're philanthropists, but in reality, they come with their hand out to the state and to the federal government to get paid.
Very good. And then one other thing that really surprised me was the blood pressure thing. And do you have some inkling as to why that is so high? Would it be aging or watching too much news or something like that?
I think it's probably multiple factors. Weight, stress, you know, we lead stressful lives, our diet, and when I say I mean our society at large. So I think that's a multifaceted
Very good.
issue.
Okay. Any other questions, comments? Very good. Well, we thank you for.
Want to make a quick comment on the? May I make a quick comment on the longevity of the program? Like the discussion here, we might not have this program because we lack of funding. That is very valid concern. You did mention about maybe consider looking to billing for some of the service we provide. Maybe we should look into that, just like our vaccination program. Again, we do have a physician on the board, so we can use my NTI to help with that project to sustain your program, because it looks like you're going to run out of funding. The other thing is, I believe the concept of education and patient navigation is important, and provide information for the patient. Patient can look right now. I mean, this conversation is not as important 2 years ago, but since AI available, it has become more important, because patient will have a lot of information from the internet, and it's good to have someone to chat with, genuinely care about the well-being for the individual. Come out there, and for me, beside providing the primary care service, I think patient education, navigation through the healthcare system is important. So I think that's important, but I'll come back down to the funding. So hopefully we can have some way to continue the program with building access, or indigent, or even some hospital. What they do is they write off on some of the indigent patient, and that's part of the credit with the government. That's just my.
Thank you, Dr. Nguyen. Anybody else? Well, very good. Lynn, thank you for your presentation today. Probably wound up being a little longer than you thought it was going to be, but we had questions, so thank you very much. Okay, for the fourth item here is a presentation on the Kennedy Cabinet Vaccine by Melissa Palmer. It says MADM, BS, MCHES, and CPM, and I'm not certain what all those acronyms are, but here's Melissa Palmer to comment on.
Good morning, Board of Health. If you ever want to know, I can run you through what each of those are if you would like. Today I'm going to be providing information on Secretary Kennedy and the Health and Human Services vaccine information as requested from the July Board of Health meeting. In February of 2025, Robert F. Kennedy Jr. became the Secretary of Health and Human Services. The first few actions that he did, he restructured the Advisory Committee on Immunization Practices, decreased the federal funding for mRNA vaccine research, and reinstated the task force on safer childhood vaccines, which was created by Congress in 1986 and was disbanded in 1998 after completing its mission and publishing its final report. This is the group that created the vaccine information statements that are currently provided to patients prior to receiving a vaccine. This is a list of current voting members as of October 17th, 2025. I had to draw a line in the sand because this list of individuals grew from the time that I started this presentation in August until October, so I had to quit updating it at some point. This slide shows a summary of recommendations for changes to the vaccine schedule that was voted on in the September meeting. So it included changing the recommendations for COVID vaccine from universal to individual-based decision-making, encouraging patients to consult with their medical provider prior to receiving the vaccine. And then the measles, mumps, rubella, and varicella is no longer recommended, and that's the combined vaccine. The MMRV is no longer covered by Vaccine for Children based on the recommendation. However, the MMR and varicella vaccines separate, so two different vaccines continue to be recommended and available to the public. The MMRV was created to reduce the number of sticks and doctor visits for children, but the group determined that the risk of febrile seizure was too high in order to continue recommending it to children. And if anyone is wondering why we have a vaccine for chickenpox, which is varicella is chickenpox, everyone who has had chickenpox in the early years, 60s, 70s, 80s, 90s, they know that it's a painful, itchy rash, but it can lead to complications such as pneumonia, encephalitis, and then permanent scarring, as does occur with any type of injury to the skin. Before the vaccine, there was about 4 million cases worldwide a year, with 10,000 hospitalizations and 100 deaths. After the vaccine, there's 350,000 cases a year, with 1,700 hospitalizations and 20 deaths. Hospitalizations, doctor visits, and the cost of medication to treat any type of complication, even the itchy sores, in an already strained medical system can be an issue. As we all know, there's staffing issues in hospitals and in other medical facilities. Medication, treatments, loss of productivity, downstream health effects, those are all reasons behind the vaccine and implementing it in the 1990s. So these are the specific votes that occurred in September. Vote 1 was for consistent and comprehensive informed consent processes as part of the consideration for an individual to choose to receive the COVID vaccine. And that passed 11-1. Vote 2 was for a prescription for someone to receive the COVID vaccine. That was tied by the board members at that time, and the chair broke the tie by voting no. So at this time, the COVID vaccine does not require a prescription. Vote 3 had to do with the informed consent. So to ensure that patients had the conversation and was educated appropriately prior to receiving the COVID vaccine, giving them the information so that they can make the informed decision for themselves or for their family member to receive the vaccine or to have their family member given the vaccine. And that passed 12-0. And that's going to be for any medical provider. That includes pharmacists, physicians, nurse practitioners, PAs, RNs, LPNs, LVNs, even EMTs. Vote 4 was for the pediatric and adult immunization schedule to be updated. Adults 65 and older vaccination based on individual decision-making, which again is that education piece. And then for individuals 6 months to 64 years, again, individual decision-making with an emphasis on the benefit of vaccination in most favorable for individuals who are at increased risk. So it's to give them an opportunity to weigh individual risks with their medical provider. Other information from the time that the secretary has been in place in 2025, or July 2025, the Vaccine Advisory Committee voted to remove the thimerosal from the flu vaccines, and that's going to be within any of the flu vaccines. However, it has been available in the thimerosal-free flu vaccine since 2003. So there has been 2 different versions. It is always, anytime you're getting a vaccination, it is always good to find out what type of vaccine, read through the materials that they provide at the time prior to receiving the vaccine, so that way you know what is going to be injected. In September 2025, ACIP postponed a vote to discontinue the universal recommendation for newborns to receive their first dose of hepatitis B in the hospital. The reason behind the hepatitis B vaccine being given in the hospital is that it is unknown. It could be unknown if the mother has hepatitis B at the time of birth, and it prevents the transmission of hepatitis B from the mother to the child. However, even if that status is known, it may not be known if somebody in the household has hepatitis B, and so that transfers through fluids, bodily fluids. And it could be even as simple as, if a family member lets the child play with a toothbrush that they've been using, and they could potentially get exposed that way. And so it was during the CDC's eradication of hepatitis B that they decided to go ahead and implement the vaccine at birth to prevent any unintended exposure for the child. And I'm open for any questions.
Questions from the board, comments? Hearing none, Melissa, I'd like to thank you for that.
I got questions. I was just giving other people
Commissioner.
opportunity.
Commissioner.
So the CDC has eradicated Hep B? Is that what you said?
No,
Or they're attempting eradication?
They were attempting to eradicate it within the states. At the same time, the World Health Organization was attempting to eradicate it on a worldly level, and then the CDC was attempting to eradicate it within the United States.
Interesting. In our vaccine program, do we offer thimerosal-free vaccines?
That I am not sure. My apologies. My nursing services manager will come up and help me with that one.
So the only one that would have had it is as she mentioned in her slides, is the multi-dose flu, and we don't offer the multi-dose flu vaccine.
Okay, so they've taken it out of the was it the mumps, measles, rubella?
I don't know if there's trace amounts in that. I would have to look.
Okay.
But yeah.
We should probably cover our tail and use the thimerosal-free version.
I think most of them are eliminated at large, the thimerosal component, but I definitely will double check on the MMR.
Sure. It also, on one of your slides, it said that that was no longer recommended, but it's still recommended.
Are you speaking to the MMR?
Yeah.
So the MMRV is no longer recommended. So it was a combination. It had measles, mumps, rubella, and varicella in that vaccine.
Okay.
And that one is no longer recommended. And it's no longer covered, thus the pulling of the recommendation, so insurance, vaccines for children. And a lot of these decisions could potentially impact whatever the insurances cover. So that's another item that everybody should know, is double check with your insurance to make sure that whatever vaccine you're receiving is covered. However, the two separate vaccines, so the MMR continues to be recommended and the varicella continues to be recommended, not the combined version.
Okay. It just seemed odd that it was both recommended and not recommended.
Just to clarify to that point, the MMRV is not recommended for under the age of 4. It can still be used for 4 and older, 4 to 12 years old.
Okay.
So it's not been discontinued,
And the V was what they think is giving the children febrile seizures?
the combo,
Okay.
in those who are younger
I don't know
than
what they
4.
gave my great-granddaughter. I could probably find out, though, if I wanted to. Interesting.
Any other comments from the board? Thoughts? Well, very good. Well, Melissa, thank you very much for that. And I want you to know that I was not poking fun at you about all the letters. It just seemed like a mouthful as far as an introduction went. So I'm sure you worked hard for all of them. Thank you.
Mr. Chairman, when I was a small child, my mother sent me next door to play with Keith. Keith had the chicken pox. I told her, but Keith has a chicken pox. She goes, oh, it's okay. Guess who got the chicken pox next week? But that was how moms got that out of the way.
That's right.
Thank you, sir.
Okay, we're going to go to item 5 right now, what I called item 5. Correct me if I'm wrong, Melissa, but is this the commissioner comments and requests for agenda items for next meeting? Or did I miss something?
We are on item 1 under official business to come before the board, and this is going to be the communicable disease report provided by Anna Scherzer, epidemiologist.
Very good. Anna, you have the floor.
All right. I chose the wrong one.
There you are.
All right, so I'm Anna Scherzer, epidemiologist with the County Health Department here. And we've got our regular old report. I don't think we have anybody new here today. But what you're comparing are our case counts. So these are probable and confirmed cases from January through September 30th, I suppose it is. And you've got 2024 numbers, so you can compare it to last year, 2025 numbers. There's a 5-year median, which tells you kind of more or less what we normally would expect. And then over in the last column on the right there is the number that are investigated. So that gives an idea of what the nurses are working through to actually get these case counts here. And the only things here that I would point out, the things that you might notice are a little bit higher than normal. Influenza, but that's just the type of year that we have. We'll come back to the measles, and we'll come back to the pertussis here a bit. But RSV is also in there with fairly higher numbers than normal. But again, that's probably just the way that the respiratory season in the year progressed. And then I've been mentioning over time here some of these invasive diseases like strep group A invasive disease and the strep pneumo invasive disease, We're seeing slightly higher numbers of that, and I'm guessing, I haven't seen it addressed and I haven't looked at it, into it too closely, but that might be a function of better reporting. So we have always had maybe some of this in the baseline, but we're just, for one reason or another, we've got some other clinics or some hospitals or some folks making better reports to us. But those I expect at some point when we have time, we can give a little attention there. So those are usually the blood infections, so they might be the things that you've heard of with people getting sepsis and whatnot. But there's lots and lots of different choices of things that can give you sepsis and can become invasive. Pertussis, I talked about last time, and you notice that we have a definitely, no question about it, higher level than normal compared to last year and the 5-year median. I think you could probably go back the last 10 years. Definitely we have lots of pertussis. It's not just us, but it's also the state of Arizona. But unfortunately, our big numbers are probably driving some of those increases in the state level too. Those cases have mostly been in the Colorado City service area, so up north. And I am happy to say that it looks like we have made it 2 incubation periods past the last case that we had reported to us for the Colorado City area. So generally speaking, if you're looking at an outbreak, if you're approaching things as if it's an outbreak, you look for 2 incubation periods without another case, and then maybe you call that outbreak over. So that's kind of the significance. I do imagine that we'll probably have a few more reports that maybe trickle in over time, but hopefully next year at this time you won't see numbers like that for pertussis. The flip side here, we're going to address a little bit more. The pertussis is more or less what I just mentioned. It was on the last report, so this is just a follow-up of that. At the point that I wrote this, I don't think we had been through those 2 incubation periods, so that's just me saying it. It's not actually here in writing. And it's one of those vaccine-preventable illnesses that we just talked about. And our cases, most of them, 90%, were unvaccinated. And then there were a handful that required hospitalization. And then the big thing that I've been talking about every time we've had a situation in Arizona, or now and then when it flares up in the country, I've said, well, if measles ever makes it here to Mojave County, it will require a whole lot of effort and a whole lot of time. And unfortunately, measles has made it to Mojave County. I don't know when the last measles cases were in Mojave County, but I know they were not since 2000. So, we're definitely 25 years having been measles-free, and now we've definitely got plenty of measles. So this information here was frozen on October 16th. So that's when I wrote this narrative here. And of course, our case counts have gone up since then. They'll go up again today. But this is what it looked like, 10 days ago, I guess it is. So the outbreak of measles is also in the Colorado City service area. And the first lab-confirmed case report that we received at the health department came in August. We got the report in mid-August, and the person had gotten sick, a week prior or something like that. So that's when we got our first case report. As of 10/16, we had identified 74 cases of measles in Mojave County residents in this area. And then Utah, of course, right across the border, has many cases as well. So at the point that I wrote this here, there were about 40 additional cases on the Utah side. We've had several case patients who have been to their local ERs, and we have, I think so far in the Arizona residents, had 2 hospitalized cases, 2 individuals who required hospitalization. And measles is, again, it's another vaccine-preventable illness. So just like you were talking about with the MMR vaccine and the MMRV vaccine. And at the point that I wrote this, 99% of our case patients were what you would say unvaccinated. So they didn't have a valid dose of MMR or MMRV when they got sick. And I think at this point here, that percentage is still quite close to being that high. The incubation period for measles can be up to 21 days, so that's really tricky when you've got folks who either don't know they were exposed, or even if they do know that they were exposed. To be patient and have a bunch of kids staying at home under my watch because one of them is sick for 21 days, that's a long time. And most people are getting sick about 10 to 14 days after they're exposed. So, you know, psychologically, you get tired of waiting for your kids to get sick. And so, you know, there's those challenges there. It's hard to isolate yourself for 21 days, even if you know that you were exposed, when you're not getting sick for about 2 weeks and you think you're perfectly fine to be out and doing things or running about life normally. So these diseases here that have these longer incubation periods are really tricky to deal with, partly because of that big, long time period. And if you want to be as safe as you possibly can, if you were exposed to measles, you would stay home and stay away from others for 21 days past your last exposure so that you didn't spread it to others. And of course, that's pretty darn difficult to do. So that's the significance there of the incubation period. And like I said, it's usually about 10 days, 2 weeks that we can see additional cases popping up when we know that there's been an exposure. So the general illness, it starts like lots of other things. You just feel like crud. So you got body aches, maybe a runny nose, congestion, sore throat. You know, think yourself, there's a whole list of things you can think off the top of your head that would pop up before measles would pop up in your list of sicknesses that you might be experiencing. But in general, the two hallmarks that we look for are eventually a fever, and it can be pretty high for some folks, and then a rash, the characteristic rash. And usually, but not always, the rash characteristically starts maybe at the hairline on the head and then spreads down the body and then disappears in the same progression there. But we're looking for fever, rash, and then cough, conjunctivitis with the eyes, and coryza. And those are the big things that you look for. Of note, again, like the difficulty with that long incubation period, measles is infectious 4 days before you show that rash. So once again, you thought you had a cold, so you're going about life and business as normal, and then the rash shows up, and perhaps you've already exposed people for 4 days without knowing and unwittingly there. And the infectious period continues for 4 days after the rash. So there's 9 days where you are considered to be infectious if you have measles. And so not surprisingly, there's been a great deal of coordination that we've been pulling forth with the Arizona State Laboratory, with the little providers and clinics up in the Colorado City area, and the schools and so on and so forth. But that's where we sit with the measles at this point. Any questions?
Yes, this is Terry Coyle. The measles, if I am correct, is a lifelong immunity. Is that correct?
Yes. Once you recover,
And the
you should have. Yes.
And the pertussis is something as adults we should get a titer for every 10 years. Is that correct?
You mean a booster or a titer?
I'd like to get stuck less if possible, but I guess we could say.
A titer will draw your blood to see if you have that immunity, or you can just get the booster shot. And the quick answer to that is you are correct. The measles should give you lifelong immunity. And that is one of the things that we look for when we see cases and are looking for potential spread. If you have documented lab-confirmed measles in your past life, you're considered immune. But yes, so the measles would give you lifelong immunity as long as you don't go through chemotherapy or end up with some health situation that might drop your immunity down. And you're correct about pertussis. That one wanes a lot. And a lot of the doses that you get for pertussis are to protect those kids who are most at risk. And the big place where somebody like me would get a booster is in care after I had a kid or before I had a kid during pregnancy. They might recommend having a booster like that. And sometimes if you get a tetanus booster, you might get the version of vaccine that also has a pertussis in it.
Thank you.
Yes.
Other questions, comments? Commissioner Gould, please.
Thank you, Mr. Chairman. Ma'am, I saw a case of Lyme disease. Do we know if they contracted that locally or brought it in from someplace else?
It's from elsewhere.
Also, there's some cases of what I think are cryptosporidium.
Yes.
Did they get that from bad water in the county?
So we don't know. We were never able to pinpoint anything down. They were not part of an outbreak, and they do watch that pretty closely to see if like the genetic strains and the DNA fingerprints are similar.
Sure.
So don't know. Can't say with that one.
How about the Giardia?
There will always be Giardia.
Okay.
And I know we think about it with contaminated water and hunting, fishing, hiking,
Sure.
that type of thing. But it can also be your animals. It can be farm animals, and it can also be domesticated animals. Dogs sometimes come down with Giardia, or the little puppies that we get come with Giardia.
No additional charge.
Free.
Thank you, Chairman.
And the Lyme disease, I will also mention, not only have we not had locally acquired cases, but we don't have any documentation that we have the ticks that spread it either.
Okay.
Although there was one situation many, many years ago, I think 30 years ago, where they did a population study of ticks in the Wallabies, and they did find one, but we've never found any others.
The Lone Star tick, or is that a different
That's
tick?
a different one. Lone Star has been down around Patagonia State Park, and I don't know, I think they've had some cases that were linked to, I hope I'm correct, but I think they've had some cases, some human cases in like wildlife biologists who had been in that state park or in that area, and that's how we discovered that it was here.
Interesting.
But they haven't found it up here in the surveys.
Thank you.
Yep.
Thank you, Chairman.
Anybody else?
Chairman.
Comments?
Chairman, I just have one question for Anna. This is Sandra Thomas again in Fort Mojave, Bullhead City. The RSV, I mean, you could see the 513 to 727 is significant. It may well be because of the growth of population in our area. But my question is, what's the demographics on that? What is the ages? What's the most common, or the spread of ages getting RSV?
So that's an interesting question. Back, I would say definitely 6 years ago, really we looked at RSV in newborns and infants because they're the ones who can generally get the sickest, especially if they're premature. And basically the only people who were being tested were little kids. So if you looked at our case counts 6 years ago, not only would you see fewer cases, but they would also all be younger. Well, since COVID came along, now we have these rapid tests that have COVID and influenza A and influenza B and RSV all in one test. So lo and behold, guess what? Now we're getting a whole lot more RSV because we're looking for it. And even back 6 years ago, we knew that some older folks were getting RSV because it was popping up every now and then when they were really sick and they couldn't quite figure out what was happening with them. And they'd run a respiratory virus panel, and then you'd find the RSV. Not because we necessarily went and looked for it, but because it was one of those 20 things that was being tested for. So we now know that there is plenty of RSV in older folks as well. And those numbers over the past, I would say 6 years or so, are definitely bigger because we're not only testing the children anymore.
Excellent. I thought that might be the case. Thank you so much, Anna. Good to see you. Thank you, Chairman.
Anything else for the good of the order? Well, very good. It looks like we're gonna, this is on the consent calendar, so we're gonna have to have a motion for this. And would anybody like to make that motion?
Motion to approve.
Maybe I should read the motion. That's to review and accept the routine summary of selected reportable diseases in Minnehaha County, January 1st, 2025 to September 30, 2025. So we have a first, looking for a second.
I'll make that
Terry
second.
Coyle, I second.
Very good. Have a motion and a second. So all those in favor, am I supposed to do this? Take the vote. All those in favor say aye.
Aye.
Same sign for those opposed. Seeing none, motion passes. Thank you very much. So now we are going to move on to a discussion and possible action. We recommend that the Mohave County Board of Supervisors set the public hearing and approve the adoption of the 2017 FDA Model Food Code, including all modifications adopted by the Arizona Department of Health Services to replace the current 2009 version. We have a staff report by Tara Stanek. Welcome, Tara.
Good morning, Board. Thank you. Tara Stanek, Manager for the Environmental Health Division. Okay, so I am presenting today on the proposed adoption of the 2017 Model Food Code. As always, here is the department's vision and mission for healthy people and healthy communities, and to promote, protect, and improve the health of our communities. The purpose and objective for this presentation is we want to highlight foodborne illness in the U.S. We want to describe our regulatory authority and responsibilities. We want to present the primary food changes between the 2009 and 2017 food codes, and to provide an overview of the adoption of our process and timeline. And then I want to discuss the potential impact of these changes and the efforts we're going to make to minimize any adverse impacts. And then finally, we would like to highlight the benefits of adopting the 2017 food code. So there are an estimated 10 million cases of foodborne illness every year in the U.S., and this results in over 53,000 hospitalizations and 900 deaths. The estimated cost is $75 billion every year, and this cost is for medical care, lost productivity, secondary chronic illness, and premature death. Now, these estimates are from 6 known pathogens, and this was from a report released by the Government Accountability Office in February of 2025. So in previous years, unknown pathogens were included in these estimates. So people are used to seeing much higher numbers where there's an estimated 48 million cases, 128,000 hospitalizations, and 3,000 deaths. So it may look a little bit different. But it really is very difficult to estimate foodborne illness because only a small portion are diagnosed and reported to public health. So let's talk about some numbers we do know. So from 2001 to 2022, there were about 9,000 reported foodborne illness outbreaks in the U.S. And an outbreak is generally classified as 2 or more people with similar illnesses and a common food source. And an investigation confirms that that food source is the cause of the illness. So in one study of 300 outbreaks, it was found that about 93% occurred in a single setting, so at one physical location. About 87% were at restaurants or fast food establishments. 85% involved complex processes requiring a kill step, plus some combination of cooling, holding, reheating, or freezing food. In over 65% of these studied outbreaks, a contributing factor was identified. So 85% involved contamination, where the pathogen was introduced into the food, commonly through poor personal hygiene or improper handling of the food. Nearly 20% involved proliferation. So proliferation is where the pathogen was able to grow, and this is often due to temperature abuse when cooling the foods or when hot or holding cold foods for service. And about 10% involved survival, where the pathogen survived the process that was intended to kill it. So usually from the improper cooking or reheating temperatures. So you might notice that the contributing factors do not equal 100%, and that's because some of these had more than one contributing factor. So a brief overview of our food safety program. We serve all of Mojave County and are currently operating under the 2009 Food Code, which was adopted by Mojave County in 2014. We issue about 1,600 annual food permits and 300 temporary permits each year. So Arizona law requires that anyone selling or serving food to the public must be permitted and inspected. So unless they are specifically exempted under this law. So we are required to have at least 3 food safety categories. So a food establishment's permitting designation and their inspection cadence are based on these categories. So type 1 is low risk with limited items or processes and are typically inspected once a year. Type 2 is moderate risk and processes, and these are inspected twice a year. And type 3 is high risk with complex processes and are generally inspected twice a year as well. So what is the Model Food Code and why use it? So the FDA's Model Food Code is food safety guidance, and it's prepared every 4 years with review and revision coming from the Biennial Conference for Food Protection. So the Conference for Food Protection is comprised of people from regulatory agencies, industry, so like food manufacturers, academia, and consumers. And its purpose is to reduce foodborne illness and injury in food establishments by eliminating the most important hazards and creating uniform standards for food safety and inspections. So once the FDA releases their Model Food Code, it's then adopted by various jurisdictions according to their purpose and needs. So these are adopted by states and then as well as local and tribal territories. So in Arizona, the statute requires the protection of food for consumers and designates the Arizona Department of Health Services as its regulatory agency and directs them to create rules. These rules are created by adopting the food code, which they do in whole or in part, and are codified in the state's administrative code. And ADHS adopted 2017 food code in 2019. So state statute also allows ADHS to delegate their regulatory authority to counties, which they do through delegation agreements, and Mojave County has a delegation with ADHS. But each county's delegation agreement will look a little bit different with what types of facilities they regulate, but all should be following what's adopted by the state. So our official process for proposing the adoption of the Model Food Code began back in January. So in January, we had an internal work group created to identify each change from the 2009 to the 2017 food codes. It developed a work plan, began the activities for its proposal, and are beginning preparing for the activities that will be necessary if it's adopted. In June, surveys were sent to food establishments along with an overview of the changes. The surveys were collected through September and then aggregated and analyzed. From July to August, general presentations were made at city chamber meetings to begin the conversation and solicit comments and feedback. And from August to September, workshops were held with food establishments and industry with a more detailed presentation and roundtable discussion. So these were done in Bullhead, Kingman, Lake Havasu, Beaver Dam, and Littlefield, as well as Colorado City. So here we are in October with, again, a more detailed and targeted presentation. It's a little different each time. And our time frame has been pushed back a bit, but we intend to present this proposal to the Board of Supervisors in November to request a public hearing and adoption in December. If adopted, the implementation of the newer regulations may take place as early as February. So a lot of changes between the different food codes are really to provide clarifying language. So I'm going to highlight some of the more prevalent and relevant changes for food service operators. So some of the less restrictive changes are amending the cooking and holding times for raw food animals. So this one's actually both less and more restrictive depending on the raw animal food type. Raw animal foods that are cooked in a non-continuous manner can follow normal cooking requirements. There is a date marking exemption for certain scallop and molluscan shellfish. There's also an exemption for foods requiring time or temperature control for safety, or TCS foods, that are vacuum packaged from needing a HACCP plan when the product is labeled, held at 41 degrees, and removed from its packaging within 48 hours. There's a lot of acronyms in that point. So, and then lastly, it amends the requirement for food ill workers, which are also less or more restrictive depending on the particular illness. So some of the more restrictive changes are the requirement for food labels to include the sub-ingredients of a main ingredient. And this applies primarily to manufactured foods and food processors. We do not regulate manufactured food. That is still held with the state. I believe we only have 2 food processors in the entire county. Also, frozen fish that is vacuum packaged must follow thawing requirements according to method. So for example, the requirements will vary whether it's being thawed under refrigeration versus thawed under running water. The person in charge must be a certified food protection manager and on-site during hours of food operation, and there must be written procedures for employees when responding to vomiting or diarrheal events. So what were the thoughts and concerns about these changes from all these meetings and surveys? So, well, the questions and comments we received at the city chamber meetings really mirror what we received in the surveys. So we mailed out 935 surveys and 840 were delivered. 9% of the surveys were completed and returned to us, which is a pretty common response rate for this type of surveying method. The survey had 4 primary questions and asked if the adoption would benefit their establishment, if there were portions that would be detrimental, if there were portions that would be beneficial, and if they supported the adoption. About 31% said that they supported the adoption, and 17% said the portions would be beneficial. Of the 55% that said portions would be detrimental, 88% of those noted the requirement of the CFPM. 5% gave some other reason, and another 5% didn't give a reason at all. So most of the questions and confusion about the food code changes revolved around these CFPM and what the requirements are for different establishments. So let's start with what a CFPM is. So a food protection manager certification verifies that the person in charge has sufficient food safety knowledge to protect the public from foodborne illness and to oversee the safe storage, preparation, and service of food. The certification is available from ANSI accredited programs and is valid for 5 years. It's a 1-day course and covers some of the same topics as a basic food handler class, but it is much more in-depth and includes active managerial controls, food worker health and hygiene, and advanced food safety. Depending on the vendor, the exam is between 75 and 90 questions with a 2-hour time limit. And the cost for the course and exam can range between $85 and $180, again, depending on the vendor. So, and depending on what risk category a food establishment falls under, this will determine what the exact CFPM requirement will be under the newer adopted food code. So the food establishments in the first two columns are already required to have a CFPM that's available, but they are not required to be on site. So nothing will change for the food establishments in the last column. The new requirement will really only affect the food establishments in the first column and will require that their CFPM is on site during hours of food operations. So it's important to clarify that the CFPM is required only for that permit type and only during hours of those food operations. So an establishment with multiple permits will only need one CFPM on site. So for example, a grocery store or a resort with multiple permits under the same owner that are on the same property will only need to have one CFPM on site. As another example, and this comes from a comment that was made in one of the surveys, a hotel that offers only breakfast service would only be required to have a CFPM on site during those food operations. So overall, of the nearly 1,600 annual food permits, there are about 1,100 that are currently required to have a CFPM on staff and available. If the 2017 food code is adopted, approximately 750 would be required to have a CFPM on site during their food service. Larger establishments with multiple permits are going to be lesser affected by the change, as are those with fewer shifts. And depending on the specific operations, some establishments may qualify for a variance. For example, if there's a facility that only receives and serves meals that are prepared by another permitted establishment, and I'm thinking of senior centers here, they wouldn't need to be required to have a CFPM on site, similar to like a school satellite facility. So there was quite a bit of concern expressed about the financial cost and the time it takes to become a certified food manager. And while I don't want to dismiss these concerns, I do want to highlight some of the benefits of having a CFPM. So there are improved food safety practices, which are going to result in fewer critical violations during inspections and thereby fewer follow-up inspection fees to the operator. The establishment gets a better inspection rating, which increases consumer confidence. There's a reduced loss of inventory from food that needs to be discarded because, for example, it's not date marked or being held at the proper temperatures. There's a lower risk of food contamination and foodborne illness, which of course reduces the risk and potential for litigation. And there's lesser negative media exposure and lost business. So given our responsibility as public health agents and our duty as the regulatory authority, we need to strike a balance between support and education and regulation. So to help food establishments with the more challenging restrictive changes for the CFPM requirement, we'll be offering certified food protection manager training and testing each month in the cities of Bullhead, Kingman, and Lake Havasu, and biannually in the Colorado City and Beaver Dam Littlefield areas. And this will be no cost to the participants. These will be available during the compliance period of 12 months and as they're being efficiently used. For contamination events, we have prepared templates that food establishments can adapt to their business needs or use as is. And for ill food worker restriction and exclusion requirements, the FDA has an employee health policy tool that can be used by both the employee and employer. So the bottom line, why adopt the 2017 food code? It can improve the food safety practices of food establishments and result in fewer critical violations. One study showed that food establishments that had a CFPM on site during their inspection were 45% less likely to have critical violations. Fewer critical violations in turn decreases the workload for our food safety program staff who are required to conduct a follow-up inspection. It would also decrease the risk of foodborne illness and the burden on medical facilities. In Mojave County, there are on average 580 emergency room visits each year for gastroenteritis, which is inflammation of the stomach and intestines. And this is typically from bacterial toxins or viral infections. Now, I don't know if these ER visits are from unsafe foods but we do know that foodborne illness is underdiagnosed and that pathogens like norovirus, E. coli, and salmonella are major causes of gastroenteritis. So it can also reduce the economic burden for both business and consumers. For instance, a consumer who became ill from food may have lost time and wages from work and medical expenses. From the employer's side, they may experience lost productivity at the workplace or may need to pay overtime to backfill a worker who is out ill. So when a person with foodborne illness loses on average 2 work days. So more broadly, adopting the 2017 Food Code creates more uniform standards across Arizona counties and other jurisdictions and would bring us into compliance with our delegation agreement with ADHS. So I know that was a lot of information and a lot to unpack, so I am open to questions.
Questions from the board, comments from the board?
Yes, this is Terry Coyle. So I have a question regarding, let's say, for example, you have a non-for-profit clubs in this Bullhead where they do a lot of popcorn, cotton candy, hot dogs, and hamburgers. Are they going to be also required to take this class and have this CPM, I'm sorry for the abbreviation, CFPM individual?
So it sounds, if I may make a supposition here, like you're talking a bit about concession stands and things of that nature. Concession stands and like booster clubs are not required to have a CFPM because they typically operate under another CFPM. So for example, a school's concession stand operates under the CFPM of that school facility, and so they wouldn't be required to have one on site. Does that answer your question?
Yes and no. What about like the Lions clubs, the Kiwanis, Rotary, in which there is no school that sponsors? I mean, we are the not-for-profit and we're selling stuff like I just mentioned.
Well, and it depends, it goes back to the food safety risk type, and it depends on what they're serving to the public would be the determined. So if they're just selling commercially prepackaged foods that don't require time and temperature control, so basically your shelf-stable items, they're not going to be required to have a CFPM.
Wow. Can you see, my concern is with a lot of these non-for-profit organizations that does this, hamburgers and hot dogs being one of the things they do sell, to have a individual on board the whole time they're serving, that's where I can see it being a little issue.
So if they are heat to serve items, those are considered a moderate risk, and they are just required to have one available and not on site. So as long as there is somebody that would be available during those operations, they don't have to be on site.
And obviously a food handler's license is just a no-go with that.
Well, everyone that handles or prepares food is required to have a food handler's license. The CFPM provides that additional training for the control of the receipt of food and the storage of food and preparation and service of that.
All right, thank you.
Anybody else? Commissioner Gould?
Thank you, Mr. Chairman. Ma'am, how would this apply? Does this apply to cottage industries?
No, unfortunately, it does not. So cottage food is regulated. That regulation is held with Arizona Department of Health Services, and they require only a food handler card.
So tamales, since the state passed the tamale bill, they're not subject, and they wouldn't have to have a CFPM.
Correct.
Back to the doctor's question, Burro Barbecue at Bullhead City puts on, I believe it's Kiwanis, I might be wrong, where they're barbecuing for the public. I would assume they then would have to have a CFPM on site during that fundraising event?
Correct.
Okay. Thank you.
Could we have an individual, let's say, like from Mojave High School that has one of those licenses, could they sign on as long as the paperwork is done?
Kind of a CFPM for hire?
Yes.
That's not something I had entertained the thought of, but certainly as long as there is an individual. And again, if you're just preparing, if you're heating hot dogs or even taking hamburgers from frozen. However, if you are barbecuing briskets, that's something entirely different and requires that CFPM on site. But for that type 2, there just needs to be one available.
One other question, just what is the food safety risk type of a food truck? Where would the food truck fit in? Is that a cottaging?
Yes, thank you. So again, it depends on what their menu and operations are. Their food safety risk is all dependent upon what type of food they're preparing and what the requirements are, their processes for preparing that food. So if it's a very simple heat and serve, that's a much lower risk than something where you're smoking a brisket for hours or you have multiple ingredients that can harbor different pathogens. So we do have 3 risk categories that apply to food trucks as well, and that's also written in the Arizona Administrative Code under their food safety rules, and they require the types 1, types 2, and types 3 for mobile food units, and they have specific requirements in there for those.
Okay, thank you. Thank you.
Ma'am, this is Terry Coyle again. Are there templates available for the vomiting and diarrheal events?
Yes, we do have the templates available, and those can be made available. I'm not sure if they're available right now on our webpage on the county site, but I will double check.
Thank you.
Any other questions or comments from the board? Hearing none, Tara, thank you for a lot of information, and right now I'm going to read a proposed motion. I recommend that the Mojave County Board of Supervisors set a public hearing and approve the adoption of the 2017 FDA Model Food Code, including all modifications adopted by the Arizona Department of Health Services to replace the current 2009 version. I'm looking for a motion and a second.
Mr. Chairman?
Yes, Mr. Gould.
I'm going to make that motion, but with an amendment that we strike the CFPM portion of the changes.
So, would I, when I do a motion for this, Melissa, would I just reiterate Mr. Gould's comments on striking the CFPMA?
That would be correct, but before we make the motion, can I just double check with Manager Stanek that that's an option for adopting the food code? It's not an all or nothing type situation, is it? I just want to be sure before we move forward on that.
Thank you, Director Palmer, and I may have to lean on the county attorney here. So my understanding is we can adopt, as the state does, with the revisions that we deem appropriate and necessary for our jurisdiction. However, what we are adopting is, yes, it's the FDA's model food code, but truly it's the Arizona State Food Code, because that's what the Arizona Department of Health Services has adopted. And through our delegation agreement, we are supposed to be aligning our practices with what are stated in the Arizona Administrative Code. So if we adopt in part, we're going to need to go back and revisit our delegation agreement with ADHS.
Thank you. Attorney Mitchell, do you have anything to add to that?
I don't. I agree with what Director or Manager Stanek mentioned.
Mr. Goulden.
Thank you, Mr. Chairman. In the presentation, it mentioned that we had the freedom to adopt code. I would think the freedom to adopt the code would mean that we didn't have to adopt the whole code, or really we don't have any freedom, that the state's just telling us to do it. And then this is just, once again, that I'm become a rubber stamp. Which is my complaint of the month. If you talk to Attorney Mitchell, he's aware of this.
No, I understand.
Thank you, Chairman.
Honestly, this situation is somewhat problematic. Just dealing with the health code. I mean, I have to go through 4 different documents just to figure out if there's a health code violation. Director Stanek is correct, though. There is leeway on, we can pick which amendments we want to make to the code. However, the administrative code said it needs to be in line with their code. So there is somewhat of a contradiction there. I think it's up to the county to then decide what liability do we want, right? So if we have a code that's vastly different than the code that's recommended, are we going to be on the hook with that? Are we okay with those changes? It is up to the county. So we can make the changes. I would not say this is a rubber stamp issue. However, a lot of the documents that we have to resort to require that we adopt their code. So I'm talking in circles here, but because the documents we have are circular. I don't want to go too much into it because maybe I'm answering too much to your question, but we have statute. We then have the ADHS, which has then been delegated that authority. We then have the delegation agreement, which requires that we use the Arizona Administrative Code, and then we have the food code. So it's a lot there. I don't want to give an answer yes or no because I don't have an answer yes or no. However, my advice is we adopt the code as best we can, but if there are changes that the board, which this has been able to go up to, really has problems with, we then take that as needed. So I think you can make that recommendation to the board that we drop the acronym CFPRM portion, and then if the board desires to do that, I would say take that up at that time. Sorry for the long-winded answer.
So, Mr. State's Attorney, then am I hearing this right, that we should maybe adopt the whole thing, and then the board, when the board meets, that they could amend that as needed?
It'd be easier for you, but you don't have to.
Mr. Gould?
You have to rule on my motion. If no one
Right.
seconds my motion, then the motion fails for lack of a second.
Yes, there is a motion on the floor, and we do need a second to that, if anybody's willing to do that.
Yeah, this is Terry Coyle. I second the motion.
First, I have a first and a second. All those in favor say aye.
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 All those opposed, same sign. No ayes on the denial, so the motion passes as is. Is that correct, Mr. Attorney, as is, or with Mr. Gould's amendment?
The motion was for Mr. Gould's amendment. So.
Okay, and then, so we'd go back and then pass the original code? Or would that encompass Mr. Gould's request?
My motion included the stock motion, so I believe it just passed.
From what I understand, the motion was pass the code, but with striking the
That's what I heard. It's just kind of confusing here with the
Son of my
nature.
sneaky legislator.
Well, looks like motion passes then. So we can move on to the next item. This is for discussion and possible action to approve the Board of Health meeting schedule for the 2026 year. And the schedule's in front of us. I don't think anybody's going to present anything on it. Is that correct, Melissa? So it's up to this board to yay or nay the schedule.
I'll make the motion to accept the schedule.
Looking for a second.
Second.
Motion and a second. Motion moves to a vote. All those in favor say aye.
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 All those opposed, same sign. Very good. The schedule is set, so we could put that in our Google calendars, I guess. We're going to have a presentation and recognition of the Mojave County Department of Public Health for achieving reaccreditation status by the Public Health Accreditation Board. Staff report by Melissa.
Thank you, President Litz. The department there it is. We were notified that, and I did send it out to you in email when we were notified that we received accreditation status. Just so that everybody's aware, the National Accreditation Program sets a high standard for more than 3,000 governmental public health departments across the country. It's a roadmap for continuous improvement, ensuring that services we provide are of the highest quality and that we remain accountable and credible to our community, elected officials, funders, and partners. Accreditation pushes us to do better every day. It gives us a clear framework to set priorities, allocate resources wisely, and receive measurable feedback on where we're strong and where we can grow. Ultimately, it helps us better protect, promote, and preserve the health of our community. But today, I want to take a moment to recognize something truly special. This achievement reflects the dedication and hard work of our public health employees here in Mojave County, who not only met national standards, but did so by ensuring that the unique needs of Mojave County were honored. Unlike large urban centers, rural health departments like ours face different challenges. It was incredibly important to us that we met these measures in a way that reflects who we are and what our communities need, not us meeting their standards by doing exactly what they stated, but us presenting our county and our department in a way that met those measures. This certification is not just a milestone, it's a testament to our commitment to rural health and to the people of Mojave County. Thank you.
Excuse me, questions, comments from the board?
Good job.
Thank you. And for any board members who are here today, if we could do a group photo after the meeting, we'll do it right in front of the rock wall to the side. Thank you.
Very good. Now I see the next item that we would, is there any commissioner comments or requests for agenda items for the next meeting? Hearing none, I would entertain a motion to adjourn this meeting.
So moved.
Looking for a second.
I'll second.
Moved and seconded to adjourn the meeting. We stand adjourned.
Thank you.